Good afternoon, everyone, and welcome. I'm Ankit Sanghvi, Executive Director at Texas Health Institute and co-lead for the Texas Primary Care Consortium. I'm genuinely excited for today's conversation. We have an incredibly strong panel with us, and the topic could not be more timely. Before I get started, just one quick housekeeping announcement. We encourage questions throughout the webinar, but please do use the Q&A box at the bottom of your screen for sharing questions. We have dedicated time towards the end of this discussion to take questions from the audience. As open enrollment unfolds, we are beginning to see early signals about what 2026 may hold for coverage and its implication in Texas. Implications in terms of what does it mean for access, affordability, and sustainability of primary care for all Texans. I'm especially looking forward to the thoughtful perspectives that our panelists will bring to today's discussion and really the kind of dialogue TPCC was created to convene. So thank you again for joining us for today's discussion. Next slide. For those of you who are maybe newer to our work, the consortium is a statewide collaborative initiative co-led by Texas Health Institute and Texas Medical Home Initiative with the sole focus on strengthening primary care for all Texans. We convene clinicians, payers, employers, health systems, public health leaders, policymakers, philanthropy, beyond and in between around one shared goal, and that is ensuring primary care works better for patients, for clinicians, for communities, and for the healthcare system as a whole. Next slide. Our work at the consortium is guided by a simple framework: educate through trusted data and shared understanding, activate through dialogue and alignment across stakeholders, and transform by advancing consensus-driven strategies and solutions that strengthen the system over time. Next slide. We anchor this framework in the pursuit of our three goals: increasing access to high-quality, cost-effective care, improving the financial stability and vitality of Texas's primary care system, and strengthening primary care as the foundation of a sustainable healthcare system for all Texans. And today's discussion sits squarely at the intersection of all three. We wouldn't be able to do this without the support of our partners. And particularly for this webinar, I want to emphasize our key partners and recognize them for their support: the Episcopal Health Foundation, the Texas Academy of Family Physicians, Texas Association of Health Plans, and TMF Health Quality Institute. Their investment and support allows us to host conversations like this, grounded in data, balanced in perspective, and focused on real-world implications for all Texans. We are deeply grateful for their partnership. So before I move to our experts, I wanted to kind of take a few minutes to contextualize why this discussion and what we have to unpack. By now, I'm certain many of you have seen news articles, updates on ACA signups. That's been the story or the headline the last several months. And the verdict is that early open enrollment data show a record number of Texans signing up for ACA coverage in 2026, almost close to 4.2 million, growing from just under 4 million. That it was more in that 3.9 million range in 2025. And again, Texas continues to lead the country in terms of year-over-year ACA signups. It is a meaningful signal, but at the same time, there is a story this does not communicate, and something that we'll try to unpack through the nuances as part of today's discussion and as part of our work through 2026 and beyond. First, enrollment does not equal effectuated coverage. That is a data, and that is a data point or an indicator we will need to continue watching on how many individuals ultimately pay premiums and maintain coverage throughout the year. Second, more interestingly, this year, it's important for us to watch in the shifts compared to 25, but also throughout the year as the story unfolds, shifts across metal tiers and its ability or impact on actually ability to access. That is, we are going to anticipate more enrollees, beneficiaries moving from silver or gold plans into bronze plans. which will potentially um, increase or have implications for out-of-pocket exposure and how patients access primary care. A data point that I wanted to lift up even before the open enrollment kicked off as part of federal rate filings, all ACA plans currently offering a plan in the Texas ACA marketplace. Across board, on an average, it was projected to have about a 34% increase in premiums. So that's part of the context or background that we should be watching out for those, which really drives home the point that affordability and the ability to access care matters beyond enrollment. Um, and so while the headline, again, as part of the takeaway, and we'll unpack as part of today's discussion, is that we are going to, it's encouraging to see the record signups. The story is about that durability of coverage and meaningful access throughout the year. Which brings me to the other part of the equation, that while ACA, next slide, while ACA has taken a lot of attention over the last several months, and as part of the open enrollment season, let's try to understand what is the coverage mix in Texas to help us contextualize both today's discussion, but also the implications, solutions, and strategies that will hopefully emerge as part of this dialogue, but work will need to be continued over the rest of this year and beyond. Even before all of this attention around enrollment and of the ACA subsidies over the last 3 years, this is a composite mix of what I've put together. That if I looked at data from 23, 24, 25, while there have been some minor shifts, pretty much this breakup of the pie has been consistent through this last 3 years, with employer-sponsored insurance covering almost half of all Texans. 46% has been that average. It's kind of hovered between 45 to 47% over the last 3 years. Individual market, which ACA is what you have to tie that data to, has grown, but it's still in that 11 to 12% range, or that's been consistent with trends over the last 3 years. Medicaid is in that range of 13%, followed by Medicare, and then again, we are home to 18% and the largest uninsured population in the country. The reason I put this into context is for a couple of things. One is, while ACA enrollment growth is important and it shows in the way this mix is shaping up, it's really where shifts have occurred in the employer-sponsored insurance in the commercial space, in Medicaid policy, that are likely to have broader system-wide implications when we think about primary care access or primary care viability through 2026 and beyond. Specifically, through the passage of the One Big Beautiful Act back in July and the Medicaid changes that were included, including expanded eligibility checks, the administrative requirements, could increase churn and disrupt continuity of coverage. It has implications, particularly for our safety net providers and system, and largely broadly for primary care access. Speaking on the employer side, market dynamics as a result of all of these changes are including employer benefit design and cost pressures that are shaping employer-sponsored coverage as we go into 2026. So in other words, and to really open this and bring in the experts, the moment is more than enrollment totals and what the numbers tell us. It's about how this coverage dynamics ripple across the entire system, and the solutions, both the issues but also the solutions it should be pointing us and driving us towards. So with that, again, as I said, I'm excited and blessed to have amazing partners and experts join us for this discussion. Again, our hope is to help us unpack this story, identify what this means, what this does not, but where do we go from here? And again, it's my honor to be joined today by Stacy. She's a senior research fellow with the Center on Health Insurance Reforms at the Georgetown University McCord School of Public Policy. Also joined by Joe, Chief Financial Officer with Community Health Centers of South Central Texas, and Jamie, Chief Executive Officer with Texas Association of Health Plans. Stacy is going to help us interpret this early numbers and what they mean in the broader Texas coverage and policy context. Jamie will help bring that payer lens on how these trends and market shifts are affecting access in primary care. And Joe will help us ground this conversation in the frontline reality of FQHC operations and the communities they serve. Again, thank you, all three of you, for joining us and everything you do. With that, Stacy, if I may begin with you. Again, we have looked at this data points several times over the last few weeks. Again, I put that Texas coverage landscape in context. So beyond this headline, what do these numbers actually signal in the broader Texas healthcare coverage context? And what should stakeholders, including those of them joining us today, should understand that may not be obvious, or things that we have to do more unpacking?
That's a good question, Ankit. Thank you. And thank you for the opportunity to join you guys today. I think first I'm going to just back up and make sure folks here know that in the marketplace covers Texans who don't qualify for Medicaid or Medicare, and they're not covered through work. So they might be between jobs. They might work for a small employer. They might drive for Uber. They might be the parents of kids who are on Medicaid and CHIP, right? So it's a really crucial access point, even if it's relatively small compared to employer-sponsored insurance, because these are folks who can't get coverage elsewhere. And what happened this year during open enrollment is coverage got a lot more expensive for most people. Most people in the marketplace get help, get financial help. We call them premium tax credits. They're subsidies. And Congress boosted those subsidies for several years in a row, but that expired because Congress didn't act to extend it at the end of last year. So what Texans who had subsidies saw is their net premiums more than double because their help was reduced. And that's going to affect enrollment, right? So what Ankit gave us on the headline numbers is that enrollment went up in Texas and shrinking nationally. So it went up about 5% in Texas, and we have final numbers. Nationally, we don't have final numbers because 20 or so states have their own marketplace. They don't use healthcare.gov like we do. But the early numbers show that enrollment's gone down about 5% nationally. So it looks on the surface like we dodged a bullet in Texas. We certainly have fared better in initial numbers. But I think what we can't see today, but will roll over time, is kind of what's behind those numbers, which Ankit is getting at. One is 4.2 million people selecting a plan is not the same as 4.2 million people having coverage on January 1st or February 1st or March 1st. Not everyone's going to pay, particularly this year, where again, people saw their net premiums on average go up, more than double. So some folks enrolled thinking, oh, Congress is going to figure this out. They enrolled back in November and they thought Congress is talking, they're negotiating, this might work out, and they had to cross their fingers and hope for the best. And they might not pay their January bill or their February bill. There's other folks who were what we call auto renewed. So if you have job-based insurance and your HR comes to you at open enrollment, says fill out these forms, and you do nothing, they're just going to keep you in the same plan you had last year. The marketplace has the same thing. If you don't go back and choose a new plan, you will be re-enrolled in your same old plan. And in that case, folks wouldn't have gotten their bill to see what their new premium is without this extra help, this extra federal help. They wouldn't have gotten that till late December. And it might be that when they open that bill, they realize they could not afford the premium without that extra help. So we might see a lot of cancellations now, and other states that release more data are seeing that, or this quiet canceling where you just don't pay and it takes a lot longer to show up in the data. Auto enrollment's been really important. Auto renewal has been really important in Texas and nationally. Last open enrollment, more than a third of Texans renewed their coverage through that pathway. So last year it was 1.5 million people who use that pathway and who might be surprised when they get that bill. And the other thing Ankit also talked about is people changing plan levels. So in the ACA, all the coverage has the same benefits. It's got essential health benefits. It's maternity, it's well child visits, it's hospitalization, prescription drugs. But the difference is it's classified or categorized into different groups to help people shop. So there's bronze, silver, and gold coverage. Gold coverage has a high premium, a low deductible. Bronze has the high deductible, the low premiums, and silver's in the middle. And what we see out of states, again, there's some states with their own marketplace and they're releasing more data. they are seeing a very clear trend of people moving from from silver and gold plans, the low deductible plans, to bronze plans, the high deductible plans. I assume that's happening in Texas too, and we'll get data in a few months to show. But if what's happening in other states is happening here, because people are trying to cling to that coverage, to do so with the higher prices, they have to, pick a higher deductible plan. That's going to have some really big impacts. The average deductible nationally in a silver plan is $3,000. That's not small, but the average deductible in a bronze plan nationally is $7,500. That's an individual deductible. For a family, that'd be $15,000 a year. So those are very high deductible plans that people might need to move to keep their coverage, to keep their monthly payment an amount they can afford. They might be moving to plans with, a $15,000 family deductible. And it's not just that huge amount up front, different benefits that used to be in a copay. If you went in a gold plan, maybe your prescription drugs would be a copay, or your physical therapy would be in a copay. If you go to a bronze plan, it might be that those are subject to your deductible first and then coinsurance. So people will be facing much higher out-of-pocket costs when they had to make this trade-off to keep their coverage.
Thank you. Jamie, I'll move to you from bringing in that payer perspective. From your vantage point, how are you seeing these patterns shaping access to primary care, and any early signals you're picking on in terms of implications, both from a patient perspective, but also from a practice perspective?
So I'll build off of a lot of what Stacy said. So one, there's a lot of uncertainty right now. I think plans are expecting people to not pay premiums. We just don't know how much. I will say that I was surprised by those initial numbers. I think most of us that work in this space were, knowing how expensive things were. I think people were really counting on Congress to do something and solve the issue. But one thing I feel like I've learned since 2021 is that people want health insurance. Everything is getting so expensive and the risk is real. To have just any kind of even moderate health event happen in your life. We used to think of it just being as a major crisis, a big one, that it was going to cost you, but a minor health issue can really bankrupt you at this point. So those early numbers tell me that people do want health insurance. So it's not that they don't want it, they want it. So when we see people not buy it, it's going to really be that they just don't have the dollars for it. And when we would go and look at the numbers, around a couple or a family, especially older Texans that weren't quite ready for Medicare, the dollar amounts for them to pay these premiums when the time comes, there's no financial reality where they can pay them. So they're gonna have to drop that coverage. Now, what does that mean for primary care? I think one, if we see a larger number of uninsured individuals that have had health insurance previously, and especially that may have had relationships with community health centers or FQHCs or certain kind of primary care providers, they may really still want to have that healthcare and that service. And so I think there's going to be a real issue and a need for providers to be prepared for cash pay situations and patients. And I think we kind of got used to not having that, right? Remember the old sliding scale based on your income, and there was a real focus on that. So it's sort of a return to that a little bit. So one, I do think you're going to have individuals who now have had access to healthcare and want to have access to healthcare, not have health insurance, that have gotten used to using it. Two, as Stacy was bringing up, we think people are going to be moving metal levels, right? So, and I think there's a key part that I don't think you mentioned, Stacy, was that also, if you have a silver plan, that's the only way you get cost sharing reduction help. So now, how does this work with primary care? Well, primary care is usually first dollar coverage or one of the preventive health benefits. So you typically should not have copays for those services, and it's first dollar coverage, so the deductible issue should not be an issue. Except for when you look at things these days, people going in for kind of what I consider primary care services that aren't that first preventive visit, I am seeing a lot of extra fees on those, and I am seeing a lot of larger co-pays. I mean, some of those preventive health services even have facility fees sometimes, so you're seeing that kind of thing. So you're talking about people having larger bills, even in that primary care space, where that first dollar coverage protection is not there. And now if they have $6,000, $7,000 deductibles, like this is going to get bad. So on this is maybe you're fine for a little bit of primary care, but I don't know what a doctor, what a doctor or nurse is going to do to refer a patient somewhere else and then actually be able to pay that out-of-pocket deductible. So it's great for healthy people. It's going to be really bad for people who have chronic illness or a sudden illness, right? So once again, I think that falls into that category. I also am seeing, I feel like we had seen a lot of what I would consider alternative coverage items max out for a while. I think people have heard of Health Ministries. They've heard of some of these other things out there. And you kind of, there'd been a lot of bad news articles, people's claims not getting paid, things like that, because they didn't have the same protections. I think you're about to see a lot more interest in alternative coverage. I feel like even as a small employer, brokers were pushing that a bit. So for small employers who were buying it, or for individuals that were showing up to a broker and saying, I can't pay that premium, what are the other options out there? I think people have gotten used, like I say, they want health insurance. They want something, so they may go buy something. And that something they may buy may work great, it may not. They may just go buy direct primary care without any other coverage. Like I think people should be prepared for a weird mix of things, and it just to not be that. I'm sure people are like, insurance isn't clean cut either, but where it's a copay and those pieces, like I think it's gonna get a whole lot more confusing. And I don't think that trend's gonna change, because as we talked about, while the subsidies made everything more expensive, everything was just getting more expensive. And I mean substantially more expensive. The numbers that we're seeing are just crazy increases in prices, but also utilization. And we kept thinking, at some point, month after month, it was going to go down, but it just keeps going up. We are way past where we were pre-pandemic on utilization. So I would say people are also wanting to use their health insurance. They're wanting to use healthcare, or they're needing to use healthcare. So that's also just going to put a lot of burden on primary care providers and capacity purposes. So I feel like all of these things are coming together, and it's going to put a lot of stress in the system. I do sometimes think that it allows for innovation. So I don't want to be like, this is all bad. I don't think all the alternative coverage options are bad. I think you could have some interesting things. You could, on those pieces, I think the main thing to take from this is I think people are going to be prepared to be flexible and meet people where they're at, and know that there's going to be some confusion around coverage, and then there's going to be some need for more cash pay options.
Wonderful. And I want to hold on to this weird and this new options, or the landscape is kind of evolving, and in some ways you have to keep your eyes open in terms of, maybe there is something good here. So I'll come back to that. But Joe, would love to bring you in this discussion again, as both Stacy has shed a light on what this means from that plan changes, and as a result you're going to see a behavior in terms of access. And then Jamie has alluded, right, like this dynamic is you're going to, as a practice, now dealing with many unknowns, and that diversity is going to add to more complexity. So given the world you are in, how are this coverage dynamics showing up on the ground in FQHC primary care operations? And what are you seeing in terms of patient mix, access, or financial pressures?
Yeah, from a FQHC perspective, I think coverage changes show up. They're going to show up operationally before financially. We're going to see more eligibility questions at check-in. I think that's already happening, especially now it's the beginning of the year. Deductibles, all those are resetting. I think our staff is going to spend more time explaining benefits, and there's going to be more increased effort resolving coverage issues. There's still a continued turn between Medicaid marketplace and uninsured status, which is just going to add more workflow complexity there. Financially, we know that the payer mix is still shifting based off our UDS reports from the last six years, but particularly there has been marketplace growth, and we've seen that. What we are now doing intentionally is just tracking the exchange plans to better understand what those reimbursement patterns are going to look like, patient responsibility, and and long-term sustainability as well. While we still don't, while the full financial impact is still developing, we already know that that operational impact has already been immediate to what we're seeing from an FQHC ground. So it's currently where we're at right now.
Yeah, let's hold on to that. And again, I love the way you opened your response to this, as it's going to show up operationally before financially, and I'll come back to that. But to keep this conversation going, Jamie, I want to piggyback on something you said earlier, right? Like the new shifts that are happening quietly in the insurance market and offerings that certainly this enrollment numbers don't reveal. Would love for you to expand on that. Like, where are you seeing like those new offerings, solutions, or changes in the way we have thought about this, and both the good implications and the not so good implications of those updates?
Yeah. So I think the reality for employers and individuals is that they're not going to be able to afford where insurance is going to have to go the way it looks today. And at some point we're going to max out on an issue unless there's even more significant government support or some issue to actually address prices, right? Like there's only so many things you can do. And so with the extended tax, I guess with the enhanced tax credits, though, it really did make health insurance extremely affordable. I think there were some of these kind of talking points out there talking about how premiums were going up. And that actually wasn't the case in Texas. We had some really flat premiums as far as real price. So like under the subsidy, you saw the market really stabilize. You saw people come in. Now you're about to see this entire destabilization happen at the same time you're having prices go through the roof and utilization happen. And it's a real perfect storm for traditional health insurance. So before this year, we already, you guys know, we were seeing different kinds of versions of healthcare ministry, the Farm Bureau option. I don't know if people are familiar with that passed in Texas. You don't have to live in a rural area to buy that. Anybody can sign up for the Farm Bureau, and I don't mean to be an advertisement, and buy that health insurance. Now, those have no protections for pre-existing conditions, right? Great if you're really healthy, right? And at this point, if you're someone young and healthy and you can't afford this, like I can't get upset about someone going and saying, I'm going to go buy something I can afford I'm hoping will pay a hospital bill if I have a car accident or something bad happens. But so you're seeing these items come out, and but we saw them sort of max out on people enrolling in them. They sort of hit the market and they were novel. I think that's changed. And I also think you're seeing less traditional health insurance hit the actual insurance market. I'm sure you guys have heard of Curative out there, where they have no out-of-pocket costs. Right, pieces of if you do a health assessment type of thing, and they're really trying hard to build a different health plan. It's just really hard to build a health plan and be successful at it. But we just saw the entrance of a new health plan in Texas called Sidecar that got a license that has no network. It's a zero network plan. It's going to have things that look a lot like, and I don't know if it's really traditional reference-based pricing, but you're going to have to go shop for that. It's a lot cheaper if you're willing to go shop for it. I'm expecting a lot more traditional health insurance plans to be selling what I would consider shopping like plans, where it's if you go to these providers, you won't have as much out-of-pocket costs, or you're suddenly going to have these. So and then I think the Trump administration is really opening it up, right? So we've talked about bronze plans. There's something called like a copper plan or catastrophic plan. Like I'm talking absolute bare bones. And this is all great. Once again, it's all fine if you're healthy, and these are options that are understandable, but you are dealing with risk in the market and the need to balance risk and have as much of a large population in that risk to lower prices for everyone. And so all of these things and all these dynamics have interesting issues. And when it comes to providers and patients, the reason one of these plans is cheaper is because they're not paying for the healthcare, right? Like they have fewer claims. That means they're either healthy individuals or they may not always pay for things, or they may pay Medicare levels for things, as a price. So I think there's real ups and downs on this. At the same time, I don't really know what else you can do if health insurance continues to get this expensive. If hospital prices, the two drivers are drug prices, hospital prices. GLP-1s on their own are complete single percentage increases on health insurance costs. I've never seen an issue outside of mental health being added to the insurance package of it being a completely own trend, one single drug. So those are hard issues to deal with. And when it comes to, once again, I think it's the same thing. When it comes to providers and patients, if this is the direction that the market's going to keep going, then we're really going to be talking about an entirely different world. And to be successful in that world, if people are shopping, if people are cash paying, if people are having high deductibles, if people are using healthcare savings accounts, that's going to mean having prices that are easy, on these pieces. I know Curative, one of our plans, just gives people a debit card and lets them go get cash prices, right? But providers are completely confused by that situation and they don't know which price to offer them. Is it the insurance price? It's the cash pay price? What's the deal on that? Because there's a higher there's a piece on that. So I think to a certain extent, there being real prices and there being flexibility and there being more of a market in that is going to matter for everyone's success and not making patients entirely just absolutely frustrated with the situation, with where everything seems to be headed on that front.
Appreciate that. Certainly not a monolithic. And when you say difficult is because of the layers of complexity, like it seems monolithic, but not the case. But where you ended is where I want to pick up and Joe, bring you back into this discussion, given especially with the focus of the population FQHCs primarily serve, really the safety net for our underinsured, uninsured populations. So when you said like it's going to show up in the operations before the financials, and now like when I bring that patient perspective, how is it that you are already seeing or you anticipate it's going to show in the communities you are serving, or sort of the barriers they will experience as this kind of continues to unfold?
Yeah, so I think one thing that the numbers fully don't show is that having insurance doesn't always mean care is affordable, especially in our world, right? I think we're going to continue to see patients with the marketplace or other coverage who are still going to continue to delay visits because of those high deductibles or copays. As FQHCs, community health centers, the sliding fee discount program is just going to remain a critical tool for these patients. Under HRSA guidelines, patients can still qualify for assistance with, those high deductibles or copays based on their income. But even as coverage expands, we still, or I think we're still going to see insured patients needing financial support to access care long term. And that's just an important reminder that coverage and affordability are not the same thing, and that FQHCs are designed to bridge that gap. So I think when we look at that specifically, we're going to still play a crucial role, regardless of what happens with these new plans, bronze plans, silver plans, people switching around long term.
Joe, I have a follow-up. Given the way you came into the FQHC world was really in that outreach enrollment space, right? Like, and as Jay was alluding to, just the number of products and the many different like things that are hidden in that design or what they have to offer. Anything you want to kind of like connect the dots from where you started or came into this world, and as you're seeing this new landscape, is there a solution or a concern that you anticipate that can become a whole new issue?
Uh, from someone from being a CEC, helping assist clients select insurance, I think when it first rolled out, there wasn't so much complexity as there is now today. I think now it's just so many things have changed. And there's so much back and forth, so much confusion based, from a political level, that patients are just really confused on whether they want to apply or not. I think from when this initially rolled out till today, we saw less folks in our organization, from being in a rural health area, really just not want to apply, or they did get these high premiums that they just said, "Hey, we're not going to do it. We're just going to stay on your sliding fee discount program," or, you know. So I think there's just been so much more confusion today than ever that has really even though we've seen an increase in folks really apply for the marketplace, from my standpoint, we haven't really. And I think just the confusion has really pushed clients or patients to not really apply from where we're seeing it.
Thanks, Joe. Appreciate you. Stacy, we'll bring you back into this conversation. So, you shed a light on a lot of things that we do not know yet, and things we should be watching out. I would love to come back and like if I look at this with preparing for what's to come as we look at 2026 and beyond. Any insights, perspective you have to share in terms of what should we and groups such as the consortium be watching over the next coming months?
Sure. So one thing in the next coming months is who's able to pay their premiums, right? And just to explain how that works, if you're getting financial help in the marketplace and you miss your January premium, you don't pay in January, you move into what we call a grace period. And you get 3 months to try to catch back up on your premiums. So right now, lots of folks who weren't able to make their January premium payment have been moved to a grace period, and they get till March and they can in March they could still pay their premiums theoretically for January, February, March to keep their coverage. That's a pretty big lift for folks who already see the premiums increase to try to pay back, back pay 3 months. But we won't know who wasn't able to hang on to coverage until we get past these grace periods. So that's rolling out over the next couple months. Again, Joe pointed out people will see this in their clinics operationally, right? But maybe before financially, is because if somebody does lose coverage because they failed to catch up on premiums in their grace period, it's retroactively canceled back to, would be February 1st in this example. So you would have had coverage for January, but you wouldn't have retroactively had it for February and March. And that'll show up in clinics when folks are coming in and you think they have coverage when they're in their grace period, but they don't, and they're not able to catch up on those premiums. I think another thing to note long term is that these affordability challenges aren't falling evenly on folks. There are huge challenges for lawfully residing immigrants. I would say really carefully and first that undocumented immigrants have never been eligible to buy in the marketplace, even at full cost, even with their own money. But lawfully present immigrants have been able to, but some lost all financial help this year, low income ones, and then higher income, many lawfully present immigrants with higher incomes will lose coverage next year. So certain providers who are serving a lot of lawful immigrants will notice that their clients are hit. There'll be a lot more pressure put on the safety net. Joe's already talking about that when there's coverage losses broadly, but in immigrant communities and low income communities specifically. So that's something to watch for long term, because there are a lot more cuts coming through HR 1 or the One Big Beautiful Bill Act separately than these effectuate the enhanced premium tax credits we're talking about today. So lots more. And then the other thing is just we know a lot from evidence about what happens with high deductible health plans is that people cut back on care, but they're not really able to distinguish between high value and low value care, right? So there'll be a lot of need to help navigate patients to drugs that are on the formulary that they can't afford, to help them switch, to help people find care to the degree that they can, to find care that they can't afford with these high deductible or providers that they can't afford with these high deductible plans.
Thank you. I appreciate that. Jamie, from your perspective, if you had to pick top two things in terms of implications for primary care as we go into 26, what those would be?
Well, I would say one, something Stacey just mentioned really matters because this happened very early in the ACA where providers did provide services and then they suddenly didn't get paid for them. So it created a lot of anger and frustration out of the primary care community. And I don't know if they knew exactly where to place it or what was happening. It made them not like the ACA market. Like it was definitely an opposition. I don't want to see patients that have a card that's coming out of the ACA market, which is really sad because I would hate to see that sort of happen where it's just like our office it's only going to see patients that have employer coverage, right? Like we're only going to do this. And so I hate to see that happen again. That was one of the beauties of this getting so stabilized and just, it's just insurance. You have your insurance card, you have your provider, you get your services. So that's a real implication that I'm going to be really sad if it probably will happen again with this shift. And then I think the other aspect of this is really trying to find a way to be flexible and meet the market where it's headed. I know a lot of primary care docs are doing this. They do direct primary care. They do different things. They're doing alternative stuff. But that's just not going to work for a lot of what I consider middle and low income patients. But real prices and cash pay prices and like things that are reasonable for people to pay for if they lose their health insurance, or it's for services that aren't that first dollar coverage. Be thoughtful about it. I know many primary care providers are now a part of larger organizations, right? So part of why prices are higher is a lot of systems have purchased a lot of providers, right? And they're part of that system. And so you have a lot of added fees and costs that aren't covered by first dollar coverage. And I just, as someone participating in that system, I know you're not in control of everything, but you do have a voice on making sure prices are as reasonable as possible for patients, especially if they're losing their health insurance or it's not first dollar coverage and the copay doesn't help with it, right? Like I think people are gonna have to be thoughtful. It's just gonna be a real problem. And then, like I said, that flexibility piece of it. I think alternative stuff's coming. And there are going to be some bad things with that, but there could be some interesting, great things with it. Like I say, shopping, prices, other aspects of this. I think it's always great to take advantage of the opportunity and just try to do it as well as possible and as positive as possible for patients and help them with that. Last thing I will say, I just read this, and that's that there have been a lot of API, I don't know if people know what APIs are, but just connections, interoperability connections between electronic medical records and copay information and the price of something. And I just read an article that while doctors are now getting this information, they're not really using it. It's not changing their behavior when something is actually cheaper for the patient to know that. I don't know how hard that is in practice. I know that information is starting to show up. I know we're required in state law to make sure we have that going into doctors' electronic medical record systems. So they have real-time knowledge of exactly what the out-of-pocket cost for a patient is in those situations. But I do think we all have the challenge of trying to help patients and make that as easy as possible. But I assume we all have to figure it out first too and make that as easy as possible for primary care docs. So, there's two sides of that.
I'll come back to that, and I think part of it is like with a couple of questions or chats I'm seeing. But before I do that, Joe, as we look forward from an FQHC a clinic operations perspective, what does the year ahead look like? Again, in that operational space, financial space, or the clinical and outcomes we want to see.
Yeah, I think looking ahead, we still may see some continued growth in injured patients, but that will not necessarily reduce the safety net demand. Affordability pressures will still persist. Um, we we what we expect is ongoing delays in care, particularly for specialty services. I think some folks have mentioned in the chat, right? Those high deductibles, referral requirements with these ACA plans, prior authorizations, and network limitations. I think can slow access even when patients are insured to their care. Um, this is going to increase coordination work and can create reimbursement unpredictability if services are deferred. So kind of puts us there in the in-between unknowns, right? Sustainability, that will still depend on the alignment between the coverage design and the primary care delivery, including predictable reimbursement, policy stability, um, and the continued support for enrollment assistance even throughout the year, right? The special enrollment periods. I think, FQHCs will remain a stabilizing force during coverage transitions because, that's something we're structured to maintain, access even when systems become a little bit complex. So that's kind of what we're seeing looking ahead and from here.
Thanks, Joe. I'll now go to Q&A from the audience. Again, going to encourage everyone to use the Q&A option, not the chat, for sending in your questions. Stacy, I'll probably go with the first one. I hope this one should be quick. If you talked about the grace period, so if a patient receives care during the grace period and the provider is paid, will they be recouped those services?
I'm probably going to hand it off midway to Jamie, but I'll tell you how the policy works is that if a 3-month grace period in month one, we'll call that January for this example, January, February, March. In January, the insurers paid their premium tax credit from the federal government, and you have coverage, and providers would be paid, is my understanding, for services delivered in that month. But in months 2 and 3, February and March, insurers can pend those claims when you guys send them in because we don't know if that person has coverage in those months. I suspect well, I'll let Jamie say if they can recoup, but I would expect they would pend in those months. Jamie, is that how you think your plans are doing it?
I mean, that's how it's been a while since this was a problem, right? So it's hard for me to know for sure, but
Yeah.
that's how it sort of was handled, is the
Right.
claims were pended.
They are certainly
Um,
allowed. They are allowed to pend in those months.
yeah. And like I
And I
say, this was I feel like I have more memories of this from like 2014,
Oh yeah, it was way back.
2015. Yeah. But it did create a lot of anger and frustration from the provider community and a lot of feelings about just ACA plans in general that have carried to this day. But a lot of that's really evened out because you didn't really have this problem that we're about to face.
can I chime in on that?
Hmm.
From what we're seeing or what we've done from an FQH standpoint is we do have access to that information when premiums are paid or not, and we offer that self-pay portion to the patient, letting them know, hey, when you come in, the patient comes in, we're letting them know, hey, your premiums have not been paid. You may be responsible for this, or we may need to collect upfront until your premiums are paid, and then we'll reimburse you back. Those are just some of the ways we're addressing it here and what we're seeing. Because we did see that, they were coming back and recouping the money after we've already billed for the services, and the patient's like, well, why did I get this big old bill? And it's due to premiums not paid.
Thanks, Joe. Um, I'll kind of like open this next question for either of you to take a stab at. And this is the one on so there is like mention about FQHCs and charity clinics, safety net, but then there is proliferation of urgent care, and I think it's a discussion in itself. So I'll try to bring this to relevance as part of today's discussion. So in light of the changes we have seen and that we have talked about today, and what it's going to do in terms of utilization. How do you see this, growth of urgent care facilities and its impact on cost as part of some of these changes? And again, there is a tie to primary care. Um, so um, again, I'll open this to either of you to see if you have anything to respond to.
I, you know,
Jenny.
there's a tale of two different tales of urgent care now. So I would say first, it's really hard for people to get what I consider real-time acute primary care.
Yeah.
I'm sick today. What do I do? Right. And there were two solutions that showed up in the market: telemedicine and urgent care. Right. And then there's freestanding ERs over here, but we have urgent care and telemedicine. And technically, both of those were actually pretty cheap. So I have to say, it was really, we would much rather have had someone go to urgent care than the ER, right? Or use telemedicine. So I would say the proliferation of real-time acute primary care, I don't know if it's great for care coordination. I think you could debate, does it matter? Does it matter? I don't know. Does it not matter? On that piece, like I have a cold today, or I have the flu, what do I do? Do you need to get into your primary care doctor? I don't know, right? Or is there better uses of their time? But now what I would say is urgent care is being bought up by systems again, hospital systems, completely swallowed up. And so there's not really a licensure, regulation, of billing around any of these things, right? It is just technically people can make up whatever kind of billing they want. It's a little bit of the wild, wild west. So I'm fully expecting prices to go extremely high and there to be facility fees. And they're, so I'm expecting this trend of them to not necessarily be affordable, because it is especially when you see private equity show up, there's some way to max out money in the system and make money off of it, which then we all have to pay for. So there's a demand for them. There's a ton of them. If you control the entire market, you can completely change the billing for it. Then it's most likely it's going to happen. So I feel like we're starting to see that. And then that's really just turning urgent care into another version of like freestanding ERs for all of us, which are extremely expensive, either on the insurance side, the employer side, or for an individual. Because you're really going in for a flu test shouldn't cost thousands of dollars, shouldn't cost hundreds of dollars. In no way is that, the time that, the cost and time that was needed for infrastructure or that provider to provide that service. So, but that's, so I would say to a certain extent it was great, but now I don't know, right? Like, so, and that's that piece of it. Now, I do think primary care providers we have an access problem. We don't have enough. People don't go into that area. Their appointments are to the max. It's not like you can ask them to take on this burden either. So it's a really tough situation.
Ankit, I do want to chime in on this. From an FQ, working with other FQHCs, and we haven't, just because we're such rural area, but in all the areas we do serve, there are urgent care clinics. But I think some of the larger ones, down in like El Paso and other areas, they have already started penetrating into that, specifically urgent care, opening urgent care clinics connected to their clinics, where they can also get patients in. It's more affordable. And they're connecting them. If you're sick, come to the urgent care clinic. We'll get you taken care of. If you don't have a primary care physician, well, we can walk you on over to the clinic and establish care there. So I'm starting to see that. So far I've heard like one or two organizations do that, and we're kind of monitoring that, but we don't think from where we're at that may happen. But it's starting.
Appreciate that, Joe. Probably will take, I think, at least one more question And I'm going to try to combine a couple of questions and a couple of comments into one. And part of it is like, Jamie, I think you shed a light on like changes come up or create new solutions or create a new trend, whether it's from a payer perspective or whether it's from a point of care perspective. And I think that's where this urgent care story. So I appreciated the way you opened members in terms of what they are trying to do. And as a patient, you don't know like what do I, or as a clinic, you don't know what price do I quote. So there is a lot of literacy, patient literacy, clinic or from an operations perspective, staff literacy that is going to be essential to navigate through this very unique and evolving landscape. Just any perspectives either of you have to share would be welcome. Again, I'm trying to collaboratively, collectively respond to a few of the questions as well as chats that this is this is the perfect storm for a very chaotic and confusing landscape. And what are some basic things we could be doing in terms of education, simplifying the story here to help us somehow navigate?
Well, I assume insurers and providers all need to work together and collaborate and probably do a little bit better work to help patients, right? I think we could all accept a lot, blame on patient literacy and help on that. On the positive side, what Joe was just talking about is kind of what I'm talking about. Like, I think it's a completely interesting model to have a dual community health center urgent care facility. Like, that's an exact way to think about the system, what's happening in the market, the capacity issue. It's definitely a way to make some money that's viable. People are willing to do it. If you can get it at a price point that's, people can pay and it's reasonable, like that's a great model, and that's being innovative, right? You see primary care providers doing different things, trying to be innovative. Now, it's so hard when you're talking about big, large insurance and providers and change and where that meets. But you do have different kinds of products showing up in the market that are different. I would say on the positive opportunity side, it's more about just looking for the innovative option and the moment and how you move with it. Just like what Joe was talking about, like some of those facilities thinking that way. Like Joe's talking about, we can see who's on hold. Here's maybe a sliding scale amount for you to pay today so you don't have to worry about it later, on that piece. But so we can still see you. So I think there's positive ways to approach it versus just really being upset about it. Now, that's a lot of you guys that are outside of a large entity. I think if you're a part of a large health system, I think my message would be, don't just leave everything to them. It's not your fees that are expensive, it's the other stuff being added on. And primary care providers, even in those situations, they may not control decisions, but they have a voice. And what they're seeing for their patients and their patients be able to pay, if things are being added on that aren't reasonable, I would say use that voice and be thoughtful about that. So I think you see a lot of independent guys in different situations being innovative and working towards that. And I think that's great. And then if you're in something larger, a larger organization, it's really trying to use your voice and navigate that and figure out a way to make sure it's going to work for patients. Especially, like I say, if you have newly uninsured, cash pay, or high deductible situations that are happening.
Thanks, Jamie. Joe, Stacy, any remarks or reactions?
I think just for me, it's, for those of us who are kind of, in this world, right, and from FQHCs and everyone around, I think just as a reminder is that, as we continue to navigate this environment and this world, right, it's just to remember the alignment, adaptability, and just communication in what we're doing, because I think that's just it's going to get us where we need to be.
Stacey, all good?
I think the only other thing to add, and I think Jamie alluded to this, is like, the ACA, for all of its imperfections, attempted to get at issues of affordability and complexity. It tries to make the plans easier to understand, the plan structures. Didn't accomplish it. It's not easy. But if we are going to move away from that structure, and a rule was released this week to move us even further away from the structure of standardization and plans in the marketplace, then there needs to be a much broader conversation about what is actually reasonable to expect a patient to understand on a transaction by transaction basis, about how much risk they can take on, about how to maximize their benefits, about how to negotiate for services. I have very strong feelings about how much complexity we should put on the shoulders of individual patients. But it's going to have to be a much larger discussion if we want a system that doesn't do that.
And Stacey, on that sobering yet hopeful note, I want to be respectful of everyone's time. Again, thank you, Jamie, Stacey, Joe, for joining us today and everything you do to support a healthy Texas. And we appreciate you being part of this conversation and our efforts through the consortium. For those of you again joining us, we appreciate you and joining us today and everything you do to make primary care for all Texans a reality. Please do consider joining the consortium if you're working for an organization. Support TPCC in its pursuit, as well as we have link in the chat to give us your feedback on today's discussion. That will continue to inform our activities. Follow us, and the webinar recording will be on our website next week. And information will be sent out as part of post-webinar communication. So again, thank you everyone for joining us today and everything you do. And with that, we'll see you soon. Thank you.